placenta plays an important role during pregnancy, acting as a bridge between the mother and the fetus. While it serves important functions like hormone production, nutrient exchange, and immune protection, it can also hijack the mother's metabolism in various ways. How? Well, during late pregnancy, the placenta produces hormones like placental growth hormone, GHV, and human placental lactogen, HPL. This is a normal response that promotes a catabolic state in the mother. GHV drives insulin resistance by inhibiting maternal insulin action, therefore causing an increase in glucose in the maternal blood. This allows more glucose to be transferred to the fetus through the placenta. On the other hand, HPL promotes beta cell proliferation in the pancreas, increasing insulin availability. This promotes lipogenesis, where the mother uses stored fat as an energy source. When there is an imbalance of these hormones where GHV levels exceed those of HPL, the mother may experience hyperglycemia and hyperlipidemia. This can lead to lipotoxicity and glucotoxicity, triggering oxidative stress, the generation of reactive oxygen species, endoplasmic reticulum stress, and apoptosis. For the mother, the pancreatic beta cells become damaged and gestational diabetes mellitus can occur. Worse, the mother can develop type 2 diabetes, gestational hypertension, preeclampsia, and termination of pregnancy via cesarean section. As for the baby, they are at risk for being large at gestational age, childhood obesity, adult chronic diseases, and lung immaturity. According to the United Nations Sustainable Development Goal 3, we have 3 targets to achieve. Firstly, we aim to ensure universal access to sexual and reproductive healthcare services. Secondly, our goal is to make healthcare accessible. Lastly, we aim to reduce premature deaths related to cardiovascular disease, diabetes, etc. A lot of research is currently underway to help us reach these targets. One area of focus is to switch from risk-based screening, which targets only women with specific risk factors to GDM, to universal screening, which recommends testing all pregnant women. This is because studies comparing these approaches showed that risk-based screening missed half of the women with GDM. Hence, universal screening should be used as it allows better detection of GDM in the population and ensures access to quality screening for all pregnant women. Furthermore, at present, common screening tools involve glucose tests, yet ongoing research aims to develop better screening methods. For instance, certain studies show that GDM can be predicted in early pregnancy by looking at visceral adipose tissue depth, or VAD, using ultrasound. VAD is also simpler, more efficient, and more cost-effective. This makes VAD a lot more accessible. In terms of treatment, diet and self-glucose monitoring is a first step. However, there is currently no optimal approach to glucose monitoring. Therefore, more research needs to look into it. If the glucose levels are too high, then insulin can be administered. Oral medication like metformin can also be taken. However, its symptoms include hypertension and preeclampsia. Again, more research needs to look into better medication. By looking for better treatments, we can reduce premature mortality. Overall, the placenta can influence the mother's metabolism. Though this is normal, hormonal imbalances can cause risks. Therefore, it's important to implement universal and efficient screening methods to ensure early and accurate detection of GDM, as well as good treatments to be administered as soon as possible.